I'll just introduce our panelists. We have with us Dr. J.C. Suri, a very senior pulmonologist. He's heading the J.C. Suri Institute of Pulmonary Sciences. We have Dr. S.K. Jain. S.K. Jain, sir, is the Associate Director of Thoracic Surgery at Medanta Hospital, Gurgaon. We have Dr. J. Matangani. She is a radiation oncologist at Gleneagles Hospital. And we also have with us Dr. Gopal Sharma, who's Associate Medical Director, Associate Director of Medical Oncology at Max Hospital, Vaishali. So with this, I will start my discussion, sir, and we'll try to be quick. We'll try to save some time. I have only one case and I have tried to include most of the facets that we need to discuss for localized lung cancer. The case is of a 68-year-old gentleman, ECOG 1, who presented with complaints of mild chest pain with no other complaints. He was a smoker with a 30-year PAC history. He's hypertensive. He had stenting done 2 years back and is presently on blood thinners, and there is prior history of tuberculosis. This was the imaging with which he presented to us. He had a 3 into 2 centimeter nodule, a spiculated nodule in the right upper lobe. I want to ask Dr. Suri, sir, as a pulmonologist, these are very often that come to you. Probably you will be requesting CTs for some of these patients. So once they come with this CT finding, what would be the next investigation that you want to order? And these are the some ones that we have initiated. You can choose which is the next investigation that you would want to get done.
Yeah, you have already done a CT. I would, because since it is a peripheral tumor and it's small, I would prefer CT guided biopsy in this case.
Wonderful, sir. So, Dr. Jain, you would concur, or you would want to get probably a PET CT done before?
I think we need to have a CT guided biopsy to prove or disprove whether it's really a cancer before we go ahead with the PET CT. If it's some other pathology, then probably PET CT won't be required.
So, Dr.
I think
Suri,
we'll go with the CT guided biopsy, and then once the cancer is proved, then we go ahead with the other staging modalities.
Okay. So I had asked Dr. Suri at this point in time, so what other pathology you think it could be? He's a 68-year-old male, good smoking history, speculated lesion in the lung, sir.
Yeah, I think with this kind of background, the age, a very significant smoking history, and a typical, I think, CT picture when we see a lesion which is more than 15 millimeter in size with speculated margin. I think I would consider it malignant until otherwise proved.
Definitely, sir. Also, it is solid in nature. So not just the slight size criteria, but the nature of lesion being completely solid, speculated margins, peripherally located. Though there was a history of prior tuberculosis, would a tubercular scar also look like this, sir? A calcified tubercular scar, or would it be a little different than this?
No, it is highly unlikely. And if it is calcified, then it should be bone density. You know, it's not that.
Okay, so that
it should be bone density, and also then it will not be that well-rounded. You know, it will be more like a scar. You know, with the.
There should be some heterogeneity.
Yeah.
Yes, agreed, sir. And that is what is the utility of the abdominal window of the NC-CT thorax that has been done. Not just the lung window, we should have the non-contrast window as well. The screening images that you see on the left, if you can see my arrow, this is the one that we are talking about. Okay. So, but as is case in most of the...
If I can suggest...
Yes, madam, please.
So usually we prefer non-invasive investigations before we go for a biopsy. So I would prefer to go for a PET CT in case if there are many other lesions or any other accessible lesions, because this would need a CT guided biopsy. This may look, but in spite of a small lesion, we have also seen metastatic versions, though the primary may be small. It may give another lesion a possibility of an accessible biopsy, number one. Number two, it's always preferable to do non-invasive imaging, complete everything, and then go for invasive investigations like biopsy. So I would suggest to do a PET CT before going for a CT-guided biopsy.
Completely agree, madam. That is a very valid point, and that is what most of the oncologists would actually think towards. But there are actually the National Cancer Grade Thoracic Consensus Guidelines, which also approve of getting a CT guided biopsy done first and then follow it with a PET CT. Although most of the times when a patient comes to an oncologist, he's already worked up.
Yeah,
like
our
this,
mind is our
yes,
mindset
yes,
is more of oncology.
yes,
I agree
yes,
with
yes.
that.
But
Yeah.
but even when this patient came to us, he already had a PET CT done, like you said, and that turned out to be, you know, a lesion size of even lesser size, 1.8 into 2 centimeter, with no mediastinal lobe. There were no other distant metastasis. A CT guided biopsy, as sir had suggested, was done, and it was found to be adenocarcinoma. I have not gone purposefully into the pre-op of FNAC versus biopsy because that was discussed yesterday, but we now want to move forwards into management, and that is why. So if I could summarize the, so these are the CT guided image, the PET CT images of the patient. Okay.
Also, there is a, I'm sorry to interrupt, Dr. Shubham, there is
Yeah,
a paper that says that the PET CT guides us to go for an exact place of biopsy. That also enhances the biopsy results, a CT guided biopsy results, because the biopsy can be targeted at a better SUV uptake area. Sometimes, I mean, this is a very well-defined nodule. Sometimes we may have an atelectatic region also. So the biopsy may be not in the exact representative positions. So there are papers which suggested that PET CT has improved the CT guided biopsy results. So,
ma'am, that would be you are very correct. But yeah, Dr. Suri,
sorry,
please,
sir.
yes.
Yes, sir.
Yeah, I think this is a very controversial topic because we know that both the sensitivity and specificity of both CT and PET CT is low. Even if you find positive on PET CT or it is suggestive of malignancy, still you need a biopsy proof for that. But when you do a CT scan and you cover the CT scan up to abdomen and you don't find any mediastinal lymph nodes, and suppose if you don't find any metastasis in the adrenal and liver, then I think the role of PET CT would become very, very limited in a case like this, because it's not going to enhance something. So I would, as a clinician, would do a PET CT in a circumstance where, suppose a case like this where the mediastinal lymph nodes are very small, it comes into stage 1, stage 2 kind of a thing, because it is not going to improve survival, because as per the studies, I would only do it to, reduce futile thoracotomies, So that situation, suppose you want to consider surgery and through CT you have not found any metastasis, because PET CT is very good at finding the occult metastasis. That is its quality. And suppose your patient is a high risk, because this patient is a high risk case here. He is having congestive heart failure, background, this thing is there. So high risk case for surgery. Suppose if he has a occult metastasis, So then, a case like this, the PET CT has a role. If we are not finding any other metastasis anywhere else in the body, you can consider this, because PET CT is superior to simple CT in picking up occult metastasis.
So, Dr. Jain, would you? Yes, sir. I just wanted to bring you. Yes, sir.
You see, the problem with the PET CT, that particularly in the Indian scenario, that PET CT would pick up infective lesions as well. Okay, so there might be, mediastinal lymph nodes which are tubercular or infective, and tuberculosis and cancer, it does appears in so many of these patients, that where we have done the mediastinoscopy or the EBUS in view of the PET CT findings, and with a proven CT guided lesion in the lung, and this mediastinal lymph node, they have turned out to be tuberculosis either during EBUS or post-operatively when we do the mediastinal lymph node dissection. So if we are doing PET CT beforehand, okay, we will be mixing all the lesions there. Okay, we won't know whether, now the patient will have to undergo CT guided biopsy along with the EBUS or mediastinoscopy as well. So if we have the diagnosis pre-operatively that yes, the CT guided biopsy has proved it to be malignancy, then I think the PET CT will be more easily interpreted, and then we are ruling out the other metastatic disease elsewhere as well. And PET-CT to rule out the metastatic disease is much more easier, although the sensitivity and the specificity of PET-CT is again in doubt, as has been mentioned.
Sir, I
Dr.
agree
Shubham.
to this confusion of getting a biopsy versus a PET-CT done, but
Yes,
I feel you agree with me that we have to get a PET-CT done after getting a biopsy. I mean, we
Yeah,
cannot
definitely.
move without
PET-CT
a
has to be
biopsy,
done.
without a
I'm not
PET-CT.
saying that whether
Yeah,
PET-CT to be
agreed,
done or
agreed.
not done. It has
Yes.
to be done, but it's only the timing whether we need to do it
Yes,
before
I
the
agree.
biopsy or after the biopsy.
I agree on that, and I think it's more to do with the availability of PET-CT. It is more to do also with the costing of PET-CT. Also, how well so I know of places like, for example, NHS, where you cannot actually get a PET-CT done without having a proof of a malignancy, which is actually the way it should be. That you should not. That reduces the indications of getting a wrong PET-CT done. Yeah, you mean you don't want to get it for a non-malignant condition. So that is also the way forward. But let's move forward with this. That, and I want to summarize this case. That, you know, we have a 68-year-old ECOG-1, a patient who has been stented. He's hypertensive. He has an early lung cancer. Clinically, the CT picture-wise, the size was 3 into 2 centimeters with no mediastinal nodes. And now I want to get in Dr. Gopal, that as a medical oncologist, you know, many times the patient walks in more to a medical oncologist than to a surgeon, and Dr. Jain would agree with me that many times the patient walks into a medical oncologist. So when this patient comes to you, sir, what do you think would be the appropriate options for this patient?
Yeah, Dr. Shubham, this patient looks early stage lung cancer. Though age is 68 years, but ECOG is 1. And if patient fit for surgery, then the surgery is the most important treatment part in early stage lung cancer. So I would like to involve you first. Though the multimodality treatment, including radiation, medical, and surgical, is a part of tumor board discussion, but I would like to refer to you first this case. Yeah.
So we have very senior Dr. S.K. Jain sir also here, sir. So the point is that what I wanted to emphasize, and Dr. Matangni is smiling, that, madam, do you feel there's another option than surgery here as well?
There is always a controversy. See, this patient looks like a borderline. See, he's a ischemic heart disease patient, though he has been stented. We have to further go for pulmonary function test and a cardiac evaluation completely, and then decide. That will be the basis of further decisions whether we are still going to go for a surgery or an alternative options. I'm not going to say that, okay, I have an SBRT tool, so I have to do it. It's not like that. So obviously, first we have to rule out whether the patient is medically operable or not inoperable.
Madam, you don't need to be submissive. You can, you know, take the flag of SBRT higher, but Dr. Jain wants to come in. Yes, sir, please.
I think this patient has to be cleared from the surgical point of view first, only if the surgeon says that this patient is not operable for any reason. And I think this patient, whether he's having CAD or hypertension or one stent, I think that's no contraindication for surgical intervention, and the surgery will definitely give the best chance of survival in this particular patient. Unless there is a very high risk and the family or the patient is definitely against the surgical option, then of course the SBRT is one
if
of the
options
choices.
are given to the patient, then it can be discussed. That is what.
Sure.
So Dr. Shubham, you have to say no first, then the other options open. Yeah.
so
that's the reason I said we have to do a PFT to for Shubham to understand whether he can say yes or no.
Yeah. So that is what my question was, that what further information or investigations do you want it to be done to decide between the treatment management options? And like Dr. Matangni said, that we need to get a pre-operative cardiac assessment, we need to get a pulmonary function test, and I want to stroke this thing of invasive mediastinal staging because Dr. Suri is also here and Dr. Jain is also here, although we have had a very lively discussion. So Dr. Jain, what's your view of invasive mediastinal staging for this patient?
I think, since we have the facility of EBUS available at a lot of centers there, so I think it's better for this patient to undergo EBUS if there are mediastinal lymph nodes.
So there are no mediastinal
very small lymph nodes there on this, but I think this patient should be going in for surgery after the pre-operative workup that whether patient is fit for the surgical intervention, and lobectomy and mediastinal lymph node dissection. And then depending upon the staging.
So you don't want to
the
offer
treatment need
any
to be done.
mediastinal staging for this patient, sir? You don't want to offer any mediastinal staging?
I think the lymph nodes are very small lymph nodes there.
Agreed,
So I
sir.
think patients should undergo with the lobectomy and mediastinal lymph node dissection. And then depending upon the mediastinal lymph node status, then the further management to be done for this.
Dr. Suri, what's your take on mediastinal staging for suspicious looking nodes? Although this patient hasn't have any, but I want your take on this thing, sir, this controversy.
See, whenever I'm seeing a patient like this, I think what is the risk of this patient having N2, N3 lymph node involvement? Now, when the tumor is central and it is bigger, then whatever may be the size of mediastinal lymph node, the risk of having mediastinal metastasis is high. But if the tumor is peripheral, like in this case, smaller, less than 2 or 3 centimeter, if it's a small tumor, peripheral tumor, then and on CT scan the lymph nodes are subcentimetric, then the risk of having a stage N2 or N3, this lymph nodes N2 and 3 involvement is very low. So I probably would not like to go in for any, though I love doing EBUS, but in this case, it may not be very useful. You can straightway go in for surgery and do mediastinal lymph node dissection or sampling. Both things, that would be why I choose and the reason I've given you.
Dr. Mathangani, yes.
Yeah, I'm sorry to interrupt. So the thing is, we are considering a patient who is already very old, having so many comorbidities. Of course, whether we say that surgery, like very simply, that surgery may be just, authenticated treatment, it is a standard of management. But before taking such a big decision, we have to be very sure that the mediastinal staging has been done before we are taking a radical decision of going whether surgical decision has been taken on table. Because though I'm a radiation oncologist, post-operatively, if you find N2, it's going to be really difficult and it's going to be a surprise. And the comorbidity of trimodality treatment is, of course, going to be technically difficult. And additionally, being an adenocarcinoma, the incidence of lymph node staging, the microscopic metastasis may still be there, 10 to 20%. So I would suggest, if you go for first assess if the patient is really for surgical management or a radical management, to go for a mediastinal evaluation and then decide for further treatment.
Dr. Suri, sir. Dr. Suri. Yes.
Yeah, I think if you go by the guidelines given in the latest up-to-date, this is what I have mentioned to you. This is as per the up-to-date guideline in the in management of such early stage cancers, that you can actually avoid the lymph node dissection, because the lymph nodes are very small in this case, and the risk of having N2 and N3 lymph node involvement is very low as the tumor is peripheral and smaller.
Okay, Dr. Jain, please. Dr. Jain,
I have got one question to all the panelists.
Yes, sir.
Suppose we have done the mediastinoscopy or the EBUS and the lymph nodes are negative. How many lymph nodes are you going to sample? If out of 14, 15 lymph nodes which we removed during surgery, only one is positive, the chances of that lymph node getting picked up by mediastinoscopy or by EBUS is practically very little. Okay,
Sir,
so we are going to
yes.
label that patient N0 disease by the invasive investigations. Okay, so idea would be that you do the lobectomy and do the mediastinal lymph node staging, and if out of 15 lymph nodes which I take out, only one is positive, I think then it will be a better chance that this patient will get. Otherwise, what we are going to do, that we are doing the mediastinal lymph node dissection and then do the lobectomy, and the mediastinal lymph nodes are negative on the pre-operative staging. And sometimes there is a tendency that instead of doing the mediastinal dissection, you do the mediastinal lymph node sampling. And the sampling may not get all the lymph nodes positive.
So, sir, what you can see on your screen are the EST's guidelines for mediastinal staging published in 2014, and we were very fortunate to have two of the authors, Dr. Raman Ramipota and Dr. Zielinski, yesterday with us, and both of them alluded to this paper, and it is very clearly written that if the lesion is less than 3 centimeter, if it is peripheral and there are no nodes visible on a PET CT, no FDG avid nodes or no significantly large nodes, then you can straight away go to surgery. So I think it's better to always look at evidence, and the evidence of finding a node in such a patient is less than 2%. Okay, and in that case, it does not warrant to do a mediastinal staging.
It was a borderline. It is exact 3 centimeter here. That's why I was suggesting that.
Yes, I agree. But this is, and it's good to discuss such cases than to take a unilateral decision. That is the role of MDT always, and we always respect your opinion. But at the end, the evidence counts, and this is what the evidence is there existing. So we will not go for this thing. I want to bring in Dr. Suri, sir, that we have been speaking of pulmonary function test, and we have a very nice lecture scheduled after this talk on pulmonary function test. But when such a busy PFT report comes to me, I am at loss actually. What you think should be the 2 things that one should look at when we are looking at resection, sir? I have 8 minutes to finish this panel, sir. So we'll just go quickly with the next 2-3 slides.
Yeah, we basically, this patient has a background of significant smoking, 30 pack year, which is quite a lot, and we have to see this patient from 2 points of view. One is the lung volumes, and the other is the airway function. So both, now the volume also can be affected in this case because it's also a case of CAD. And if he has any kind of systolic or diastolic heart failure, because I don't know what is his echo report and whether he has diastolic dysfunction, most likely he may be having, because he is hypertensive. So if he has left ventricular hypertrophy or diastolic relaxation problem, so the likelihood of him having diastolic heart failure is also there. So this is it's a combination. So where if I find a significant mixed kind of a picture of obstructive lesion as well as the restrictive lesion, then of course this becomes quite a
but the two parameters that you would look at in this report. This is a busy report for me as a surgeon. You need to tell me 2 parameters that I need.
The vital capacity, the FEV1, and also the MVV. So the maximum capacity we see. But when you are going for surgery, you also have to see what will be the predicted post-operative lung function here. Yes. So which if there are set criteria for that, because of lack of time, I'll not, if the patient does, suppose is borderline on those criteria, then we may have to do exercise studies.
Sir, I'll touch on that. So for this patient, the FEV1 was 90% with the absolute value of 1.6 liter, and the DLCO was 78. So one thing other than the pulmonary function is the diffusion capacity that also needs to be tested, other than just the respiratory function. And what sir correctly said about post-operative predicted value, this is how we calculate the predicted value. And for this patient, this was coming out to be 75% and 65%. So, Dr. Jain, you feel this patient is fit enough for a...
Definitely, he is fit enough to be operated with these values.
So this is what the algorithm, what Dr. Suri was talking about, looks like, where you look into the post-operative predicted FEV1 DLCO and find out how severe the risk stratification is for the patient for any kind of surgery. This is taken from the Chest Journal of the American Chest Society, and you can see that any FEV1, post-operative predicted FEV1 more than 60%, DLCO more than 60% is considered to be low risk, but anything less than 30 requires a CPET or a combined pulmonary exercise, cardiopulmonary exercise testing, which actually looks into your oxygen consumption. It's a VO2. Combined test. Yes, VO2 max. So, and this is how what the VO2 max looks like, where you actually look into your oxygen consumption during exercise, which takes care of both your cardiac as well as your pulmonary function. Sometimes there are some surrogate tests which are actually not as big as CPET, but these are the 6-minute walk test, the shuttle walk test, and stair climbing test. And I'm sure as we move forward, we'll talk about them more. What Dr. Suri also mentioned was to assess the cardiac function of this patient. So the 2 cardiac investigations that we usually get is 2D echo, which is the baseline investigation. Because this patient is stented, I am very sure my anesthetist would ask for a stress echo, and that is why the echo was done, which shows this report. Now I'll go back to this slide, that what Dr. Gopal said, chemotherapy is not an option. We are looking at surgery versus radiation therapy. Of the investigations that we were looking, we have decided that we are not getting an invasive mediastinal staging. We have looked at the pulmonary function test where FEV1 is 75 and DLCO is 65%, and cardiac status wise, he is still operable. So,
mention here one thing more,
sir. Yes.
That, with the, minimally invasive surgeries now, which are becoming more and more common with multiport VAT or uniportal VATs, the criteria of having this PFT can be further relaxed to in number of patients there. Those who may not be able to tolerate the exploratory thoracotomy, full-fledged thoracotomy, they may be able to tolerate multiport VAT or uniportal VATs, where the stress on the patient as well as on the lung is much less than thoracotomy, and the post-operative course is much more, smooth on those patients.
So with this, we have come to a conclusion that the patient is medically operable as well. Okay, but now the patient's family refuses surgery and they really want to take a non-surgical option. So my question to Dr. Matangi, and these are going to be your final words, madam, because we are running short on time as always.
So this patient, though he is fit for surgery, we can give him the alternative option of stereotactic ablative body radiotherapy. I would choose, because it is situated little 5 millimeter, more than 5 millimeter from the chest wall, and it is just 3 centimeter in dimensions. I can still go for 3 fractions of treatment.
So would you be happy telling the patient that the results are as good as doing surgery for this patient? Would you tell them with the same confidence that, even if you do
2-year and 3-year local controls for all our SBRT patients, reports have been showing equivalent results, 95% local control rates and 85% survival rates, almost similar to the surgical data. And for this patient with such a small tumor and a peripheral location, the complication toxicities will also be further reduced. So I would be comfortable doing this if the patient refuses, and it would be an equivalent option just because the patient refuses. But of course, I will say the present standard guideline is, of course, a surgery. We have to explain both the importance and, of course, but if the patient refuses, they always have an option.
Okay. Dr. Jain, your last few words on the management for this patient.
You see, the standard of care for this patient, surgical approach would be a lobectomy. But now there are many reports which are coming up for the sublobar resection also, although probably it might not fit into, exactly into that criteria. It's around 3 centimeters. So about, 1 centimeter, 1.5 or max 2 centimeter lesion will qualify for the sublobar resection. Wedge resection or a anatomical, sublobar resection, I presume it's a, anatomical segmentectomy. Okay, that is a possibility there. And several studies are now proposing that the overall survival in these patients is almost equivalent to the lobectomy. But still, a lot of centers, they will still go in for the lobectomy for this particular patient. With
agreed, sir. And these are the criteria for sublobar resection that, as sir said, the lesion size has to be preferably less than 2 centimeter. You would not want to go for lesions as big as 3 centimeter for a segmentectomy, and you should always attempt an anatomical segmentectomy. This is my last slide, and this is for Dr. Gopal, who has been patiently waiting for the resection report for this patient, sir. Very conveniently, the tumor size is 3.2 into 2.6 centimeter. There is no perineural spread. There are no nodes. We did a very good surgery. 18 nodes came out. We sampled all the required stations, the 3 mandatory as well as the hilar. So is there a role of chemotherapy?
Yeah, in this case, there is no role of chemotherapy as well as TKI. The role of adjuvant chemotherapy in non-small cell lung cancer comes after T2, N0, M0 onwards. In T2 tumor, if the tumor size is more than 4 centimeter, if only represent carcinoma, there is invasion and there is pleural invasion, or there is wedge resection. So these are called high-risk feature. If these high-risk feature are present, then adjuvant chemotherapy play definite role in T2, N0, M0 also. And
thank you, sir. Thank you.
Yeah.
I think that is what we wanted to emphasize and set the tone for the day. Thank you. I thank all my panelists for making it a very interactive session. Thank you so much.
Thank you, Shubham.
Thank you, Dr. Shubham. Thank you.
It was a very interesting discussion, and we thoroughly enjoyed it.
Thank you.
Thank you.
So it was an excellent discussion. Thank you, Dr. Shubham, Dr. Suri, Dr. Mathangi, Dr. Jain, and Dr. Gopal.